So we're now a musculoskeletal system. These injuries are based on the mechanism of injury, and we talked a little bit about some of these forces. So we have penetrating trauma, we have blunt force trauma, we have rear ends, we have front collisions, we have lateral impacts, we have it's like a rotational impacts, we also have the rollovers, we have falls, we have penetrating trauma. So we have to take into account all of these issues. Now remember, the periosteum is quite, I wouldn't say vascular, but it does have a lot of blood flow through it, and so it can bleed a lot. So let's keep that in mind. Now this is going to be a short presentation because as far as musculoskeletal injuries go, we're looking at the actual structure of the bone itself, and we're looking at potentially maybe the joints that connect these bones together. But we're really looking at these fracture sites, and so when we look at these fractures, just ideal is to think about the bones. So as we go down, they're pretty much ribs. Then we want to stabilize those ribs, and we want to think that there could be about 100 cc to 50 cc loss of blood just in there. If we're looking at the lower upper extremity, which is the humerus and the ulnar, we might look at about 100 cc's blood loss there, and we want to stabilize that. You would use some type of splint with a sling and swat, maybe the humerus, which is about 200-250 cc's, that can fracture, and very hard to break, but it is something that can break. Think intentional injuries sometimes, and we're looking at about 200-250 cc blood loss there. As we look over the femur, we talked about larger blood loss into the femur, maybe 3 liters, and then lower extremities we can estimate just under 500 cc's of blood loss there. Now, when we talk about these isolated extremity and long bone and musculoskeletal fractures, we want to splint them in place. We want to stop any bleeding, and we want to try to put them back into the position that they are normally lying. So once we've done that, we're looking at taking care of the analgesic or pain tolerance for that. So fluids, get your IV access for fluids, medication administration, which would be narcotics. In the past, I mentioned morphine, and then I had a little mind block about fentanyl, but these are your narcotics that you're going to probably want to give for those limb or extremity or musculoskeletal type injuries. Again, there are some specifics, but look for first inspect and see whether there's shortening and anatomically derangement from normal position. We want to replace them back into normal position, checking the distal parameters prior and after your movement, because if you did something to arrest blood flow or movement or sensation, we want to make sure that you try to reduce that and make sure that it goes back into place. To replace the blood flow or nerve endings or muscle. Now, as far as splinting goes, splint above and below the fracture site, never over joint space. And we talk about specialized treatments like traction splint, which is only used for a specific type of injury, mid-shaft femur fracture, which is closed, and you're able to do so. If not, we want to think about anatomical splinting, padding in the voids, maybe even digils for like the fingers and toes. We might buddy splint those. Those are another anatomical splint. When you're trying to secure a flail chest segment over the chest wall, you might use a bulky dressing or a large blanket that you kind of pad over that area. Now, when you talk about the pelvic girdle, which is another like musculoskeletal injury, it may require you to have a lot more resources. You may need to secure that with straps. You may need to secure that with more padding. Right? As you compress, you want to bring the pelvic girdle back together. And this may have been missed in the abdominal chapter. Now, the pelvic girdle is, like I mentioned with the abdominal cavity, massive hemorrhage loss. So we want to control that by compressing the pelvic girdle together. In the past, we have used the mask trousers. And mask trousers work very well unless we go up in the aircraft, and then we have changes in pressure, which requires this insufflated device to be reinflated as we go up in pressure, and then make sure that we decrease that as, or actually on the opposite, as we go up in pressure, we want to make sure that that pressure doesn't inflate. And then luckily enough, the mask trousers was something that had a burst valve that allowed the air to escape. Now, the mask trousers is not something that we normally use and normally talk about or normally mention, but it is something that's still used by our trauma courses that we teach. So think about that, maybe using for pelvic, intra-abdominal, and then the lower extremities at least. The last thing is, if it's just an isolated extremity fracture, don't forget your RICE, rest, ice compression, elevation, and monitor your distal parameters, and making sure that everything is in place.